Thank you very much. And I'd really like to thank Banshee and the organisers for enabling me to make my first visit to the beautiful India. And I hope it won't be my last. I was asked to talk about the holistic treatment approach for people with type 2 diabetes. And the short answer to the question, for those of you who have other pressing engagements, is no, current strategies are not meeting the holistic treatment targets that we would like to see for our patients with type 2 diabetes. But for those of you who'd like to stay, I'll give you a little bit of background as to why I've come to that conclusion. So the first thing is a definition of what we mean by holistic medicine. And as a Cambridge Don, it obviously pained me greatly, but I went to the Oxford English Dictionary for a definition. And this was what it came up with: a form of medical treatment that attempts to deal with the whole person and not merely with his or her physical condition. And obviously descriptions of holistic approaches to treating people go back to the ancient Greeks, and probably even longer than that. But one of the earliest references in a modern medical journal was in the Annals of Internal Medicine. And what it referred to was integrating knowledge of the body of the person, the mind of the person, but also of the environment and the context that the person lives in. And so I'm going to touch on those elements during my talk. Now, if we want to reduce the burden of type 2 diabetes, I believe that the rule of halves still applies. So we could treat people with diabetes, tertiary prevention. We could try and find them earlier, because the number of people with undiagnosed diabetes still is up to around 50% in many countries, and that's been persistent for decades. Or we could have primary prevention, where we try and stop people getting the condition in the first place. And when I say the rule of halves applies, we know from the STENO trial that you can halve risk of heart attacks and premature mortality by aggressive treatment of glucose, blood pressure, and cholesterol. As I mentioned, we know that up to 50% of people with type 2 diabetes remain undiagnosed and therefore untreated. And of course, we know that you can more than halve the progression from impaired glucose tolerance to type 2 diabetes. So the rule of halves that was described for blood pressure, I think also applies to type 2 diabetes. Now, because the title that I was given concerned people living with the condition, I'm not going to talk about primary prevention at all. I'm just going to talk mainly about management, but also a little bit about early detection. So this is the outline of what I'm going to talk about. I'm going to talk about the organisation and delivery of care and how we can improve on that and make that more holistic. I'm not going to talk about multimorbidity and multiple long-term conditions. It's been discussed on a number of occasions in a number of sessions at this meeting. But suffice to say that the person with diabetes that I see also often has high blood pressure, chronic kidney disease, osteoarthritis, depression, underactive thyroid, obesity, etc., etc. So clearly, the management of diabetes is in the context of managing all those different conditions, which inevitably leads to polypharmacy. I'm going to talk about patient-centered care and patient empowerment. I'm going to talk about enabling environments, and then a little bit on early detection. So firstly, Julian Tudor Hart. He was from St John's College in Cambridge. He's a proud Welshman, a socialist. He was the first person who described the inverse care law, that the people with the least health problems have the best access to healthcare, the people with the most health problems have the least access to healthcare. But what he also described was that good management of chronic disease involves doing simple things well for large numbers of people, few of whom feel ill. So most of the people with type 2 diabetes that I look after fall into this category. So one of my first ever publications back in the British Medical Journal in 1998, it was a meta-analysis of trials of GP versus hospital care for diabetes. And what it showed was that if you had general practice care based on a register, based on a recall system, and based on regular review, so you called people from your register every year and reviewed them, then care could be as good or better than the care provided by hospital outpatients. Then in a Cochrane review that I was involved in, the lessons from it go back to 2001, but still are relevant. We concluded that what was needed to improve care was multifaceted professional interventions and organizational interventions that enabled this structured, regular review of patients. But also the addition of patient education was important and enhancing the role of the nurse. Nurses are much better at doctors at ticking off things on the protocol and actually doing what we should do. Doctors tend to do their own thing rather too often. And if you go through the list of things for which there's evidence about improving the delivery of diabetes care, I've summarized it here. So guidelines and audit, planned patient reviews focused on outcome-related processes, so the checking the blood pressure, checking the cholesterol, checking the feet, and then the result acting on it. Most of the good systems of care in regions or countries have been led by a charismatic opinion leader. And this meeting has reassured me that India is full of charismatic opinion leaders. Enhancement of the role of the nurse, as I mentioned. Clinical information systems, so digital and technology have a really important role to play in the organization and delivery of care, and I'll say a bit more about that. Prompting and reminders, that's prompting and reminders for the patients and for the physicians and nurses about reviewing people, what to do when you review them, and what to do based on the results of what you found. Access to specialist advice, dietitians, endocrinologists, and then patient education and support for self-management. And I'm just going to touch on a bit about IT systems. So this is an IT system that we have in the UK called Eclipse. And what you can see here is the practices are listed, and this is just the top 9 of these practices, are listed in order of the level to which they're achieving these targets. So the proportion of their patients with an HbA1c of less than 7.5. So this surgery here is the top performing practice and may not need much help. And as you go down the list, you'll find the practices that are struggling a bit more and may need more help. And if you go into an individual practice, you can then see the data on the HbA1cs and how you're performing. And you can click on the bit of the pie chart here to identify the patients with good and less good control. You can then list all your patients in your practice, and you can order them by, for example, their HbA1c. And you can see whether the HbA1c is going up or down. And you can see what medications they're on. So you can almost do a desktop review, a desktop ward round of all your 350, which is the number of patients in my practice, all your 350 patients. And then you can prioritize patients that you want to see more often. And then if we take the patient that was on the top of that list, this is the information for the individual patient. And you can see that their HbA1c was doing quite well until suddenly it increased. And the reason it increased is this person was admitted to a residential home where every day they had cakes. And so you then have a personalized plan with the list of all the risk factors, all the medication. And then just here you can see, please avoid giving cakes to this patient every day. But the other thing that's really made a difference, or we think may have made a difference, is the payment for performance in the UK. This was the quality and outcomes framework, where those key process and outcome indicators were funding was attached to them, or funding was withdrawn if you didn't meet them. And the QOF was introduced in around 2004, and you can see that the performance in terms of the quality of care indicators increased after the QOF. Now, one might argue that it was going up anyway. Now, some people have described the quality and outcomes, payments for performance, as an initiative to improve the quality of care that is the boldest such proposal ever attempted anywhere in the world. But journalists have had a different view and said that doctors have been given a 20% pay rise merely for doing what they should have been doing anyway. And there was some concern that the doctor's car park was going to end up looking like this, rammed full of Ferraris. So how are we doing in the UK? This is the National Diabetes Audit. and you'll see that actually the proportion of patients that are having all the care processes done still remains less than 50%. So we do better on some things like measuring HbA1c and so on, but to have everything done, still less than half the patients are getting all the processes done within the last year. And what about outcomes? Well, again, all three treatment targets, so for cholesterol, blood pressure, and statin prescription, blood pressure, and HbA1c, again, less than 40% of patients are meeting all of those targets. Hence the reason why I think we are not yet achieving the holistic care that we desire for our patients. Okay, what about patient-centered care, patient empowerment? So William Osler described how it's much more important to know what sort of patient has a disease than the sort of disease a patient has. And the good physician treats the patient who has the disease. And I remind many of my students and trainees that the most important drug, the most powerful drug, is in the chair, not in the formulary. So every consultation involves the doctor, the patient, and the illness. And I focused so far on disease management, and almost every lecture in this conference has focused on disease management. Rather fewer have focused on the illness experience. But actually, it's the illness experience of the patient that predicts, for example, whether they'll adhere to the medication that you're prescribing. So we gave around 800 patients who've been diagnosed with diabetes by screening at the end of their first year a questionnaire. It's a validated questionnaire about the quality of their care, called the care measure. And these are the questions here that we asked them. And what we found is that patients who reported higher care scores had a higher chance of remission. We also found that patients with a higher care score had a 40% lower risk of premature mortality, as you can see here, over the 10 years following diagnosis of diabetes. So your care score predicts your risk of premature mortality. So based on that sort of evidence, we undertook a trial where we took practices that were giving good care and we randomized them to a patient-centered approach versus standard approach. And in the patient-centered approach, we trained the GPs and nurses to listen to the patients more, elicit their views, and so on. And we gave the patients a booklet that had a box for them to write what they wanted to get out of the consultation, a box for what the doctor wanted to get out of the consultation, and lots of icons for the sorts of things that patients might want to bring up, like their kidneys, or perhaps their travel and holidays, or perhaps their sexual function. And we followed the patients up for 12 months. And what we found is that we were able to make a difference to the communication. So we improved the communication, albeit interestingly with the GP, not the nurse, yet most of the training was with the nurse. What effect did that have? Well, it had a very marginal, non-significant effect on the HbA1c. And of course, in retrospect, the HbA1c is at its lowest 1 year after diagnosis. So that was probably a wrong outcome to choose. But also the weight seemed to be higher, albeit the weight was 2.8 kilograms higher at baseline due to the cluster randomization. We did improve well-being, so patients expressed a preferable well-being at the end of the trial. So some commentators said that we'd made people fat and happy. We rather dispute that. But what it shows is that it's quite challenging to integrate disease management and illness experience in one consultation. We did a systematic review of interventions to alter the interaction between patients and practitioners, and interventions significantly improved the interaction in 73% of trials. They improved improved principal outcomes in 74%, 40% significant, and they had significant positive effects on health outcomes in 44% of trials. And even simple things like giving patients a questionnaire before their consultation that they fill in and can give to the doctor seem to make a difference. And in fact, if you focus on the HbA1c of patients in a trial of interventions to improve the consultation in people with type 2 diabetes, those that achieved an improvement in communication actually did achieve a significant improvement in HbA1c. And these improvements of 0.5% in old units are equivalent to many of the drugs that we use for treatment. Okay, what about enabling environments? So many health promotion campaigns target individuals or populations focusing on education, information transfer, and knowledge. So these concern diet. This one concerns physical activity. If you're on a bicycle, you burn fat and save money. If you're in a car, you burn money and you become more overweight. The problem is that, as William James, the father of behavioral science, pointed out, behaviors like diet and physical activity are environmentally cued, habitual, and they're not subject to cognitive processing. So targeting knowledge and education is unlikely. It may be necessary, but it's certainly not sufficient in order to change these habitual behaviors. In order to do that, we need to target the underlying determinants of these conditions. So, for example, we studied over 5,000 people and assessed the environment where they live, where they work, and the commute between home and work. And we found that your takeaway exposure, your fast food outlet exposure, was directly correlated to your fast food consumption and to your body mass index. Every conference you ever go to, you'll see this. Even a diabetes conference, even an obesity conference, everyone will be on the escalator, no one will be on the stairs. This is a cycle lane in Glasgow in Scotland. This is a cycle lane in Denmark, in Copenhagen. You won't be surprised to know that cardiovascular disease and diabetes are more common in Scotland than in Copenhagen. This is the size of a portion now compared to what it used to be. These are the 10 global companies that are responsible for almost all of the produced food that we eat, that have an enormous impact and a far greater impact than you do on the diet of your patients. There are many examples of public health successes in changing health outcomes. For example, safe drinking water, sanitation, abolition of slavery, road safety, air pollution, smoke-free legislation, and so on. And many of these have had dramatic, far greater effects far sooner than we ever anticipated. So no one thought that banning smoking in public places in Scotland would reduce heart attacks by 17% within a year. The challenge is that in order to achieve that, you need multi-component strategies over many, many years. So we have tobacco advertising, we have finances, we have nicotine replacement, etc. So multi-component strategies over a prolonged period. And the same was true for road traffic accidents. You need multi-component strategies targeting the driver, the car, the road, and the culture. And they need to be maintained. But the sort of things we could do to improve the environment and enable a holistic approach to diabetes care would be taxation, menu labeling, crop subsidy policies, incentives to promote availability of affordable foods in the community, and the same for physical activity, regulating foods in public places, and school food and physical education policies. But we know that those sort of things work. This is the sugar tax in Mexico. So after it was introduced, the consumption of sugar-sweetened beverages declined and the consumption of alternative, less unhealthy products increased. The question is, how far up the ladder of state intervention do we want to go? And unfortunately, most governments stay down at the bottom, leaving it up to individuals in informing. I would argue we need to go much higher. And certainly Jeffrey Rose would argue the same. The primary determinants of disease are mainly economic and social, and therefore its remedies must also be economic and social. Medicine and politics cannot and should not be kept apart. And the German pathologist and eminent social theorist Virchow said that medicine is a social science and politics nothing but medicine at a larger scale. So finally, early detection. So many people live with diabetes, are untreated and undetected and undiagnosed. And we know that diabetes meets many of the criteria for screening. It's common. Many people have complications at diagnosis. So we sought to undertake the only randomized trial in the world of screening for type 2 diabetes to resolve some of the uncertainties. I'm not going to talk about that today, but I'm going to talk about a related study that I was involved in Denmark. So in the whole of Denmark, around 181 practices took part in a screening trial, and that left 2,247 practices that weren't. And the screening involved a risk questionnaire and glucose tolerance testing and assessment of your risk of cardiovascular disease. So what we saw is in the screening practices, you had some patients diagnosed by screening and some patients diagnosed by clinical care. And if you look at what happened to people with diabetes, there was a 21% lower mortality in the screening practices. So in summary, I think there remains a clear gap between our goal to deliver a holistic treatment approach and the reality. This gap could be narrowed significantly through more effective implementation of existing evidence at the individual, health system and societal levels. A number of challenges remain. So how to integrate the disease management and the illness experience remains a challenge. Overcoming political and public resistance to policy intervention and the lack of evidence of cost-effectiveness of population screening in different settings, such as, for example, India. Thank you very much for your attention.